Hello viewers, I am Dr. Mahesh from Advanced Hospital Ahmedabad. We have Dr. Prathamesh sir today with us, and today we'll discuss on pediatric ACL injuries. Should we treat them or should we left them alone, and what are the different treatment options we have with us scientifically today? So Prathamesh sir, please let us know, should we treat the pediatric injuries of ACL ligament or not?
It's a very, very good question because many a times patients come to us and they say that the child's age is very small. Should we wait for the maturity, skeletal maturity, and after that we get the ACL surgery done? But the fact of the situation is, if the child is small, if the child is young, he's a very active person. Very difficult to restrict them. So whenever a child has got injury, it's very difficult to restrict him from playing or do the things in the way he wants. So whenever that happens, if the child has got an ACL injury, his knee is unstable, and he keeps on walking, playing, and doing strenuous activity on the knee, the condition of the knee deteriorates very fast, and that is literature proven. Any child who has got an ACL injury has a very high risk of developing meniscus injury, chondral loss, and a higher chance of osteoarthritis. So it's better not to wait because the child is young and he has not achieved his skeletal maturity. It is better because now we have options in which we can treat these injuries in a very scientific way without causing any skeletal disturbances or any growth disturbances. So nowadays we recommend to treat these patients early to prevent the knee from further damage and to prevent any other problems like meniscus injuries and chondral damage. So now the dictum is, if the child is young, still you can do what is called as a physial sparing ACL. There is no need to wait for the skeletal maturity.
Okay, sir. So, what are the different treatment options we have available, and whether they are age specific or depending upon the duration of the
Yes,
injury?
so it's a very, very good question. So a child is not a small adult. It is not only the size which is important. It is actually the age, and what we actually need to see is the growth potential. So the girls will attain the skeletal maturity early as compared to boys. And what we have seen is that girls usually attain their skeletal maturity by the age of about 15 years, and boys will attain skeletal maturity at about 17 years. And after that age, like 15 and 17 for girls and boys, you can make them do a regular ACL reconstruction. So if the girl age is more than 15,
like what we do in adults.
So if the age is more than that, you can go ahead and do a standard ACL reconstruction with whatever technique that you want to do. You can go ahead and do. Now, supposedly that age is less than that, and again we have to consideration the amount of growth which is remaining. Now, the important thing is a lot of growth in a person's body will happen around the knee. So the growth will be more in the region around the knee, that is the distal femur and the proximal tibia. And this is the area where a lot of growth is taking place, and whenever the height is increasing, so a lot of growth is taking place at this area. Now specifically, this is more so in case of distal femur as compared to proximal tibia. So any problem in the distal femur or any issue in the distal femur will lead to more growth disturbance issue and more growth retardation issue. And the other thing is, there are two things by which we are worried. One thing is the child should not have less growth, so that we don't want his or her leg to be shorter.
Limb length
discrepancy. So that is one. The second is a deformity that may happen, because what happens is when we do a femoral tunnel of the ACL, we ream on the lateral aspect. So whenever we do the lateral aspect, there is only lateral sided physis which is involved. And if supposedly there is a growth arrest on the lateral side, the medial side will keep growing, and that may lead to what is called as a valgus deformity of the knee. So if you do any injury to the physis, that may lead to a deformity, number one, and the limb length discrepancy, number two. So as a doctor, as a specialist who is doing specifically this surgery for a patient's well-being, we need to be very careful about how we can avoid these two things. Now, as I told you, the femoral side is more sensitive as compared to the tibial side, and you need to be more precise and avoid doing any deliberate injury on the femur. Some basic rules to it. So the first rule is in the children, never use any screw. So nor on the femur nor on the tibia, you should avoid using any screw which is through the physis. So that is number one. Now, depending on the age of the patient or the child, we will decide about what the procedure we need to do. Now, there is a procedure which is called as a total physial sparing procedure. This is described by Mininder Kocher. He's an Indian, very good surgeon settled in US. And this technique is basically Mininder Kocher technique. And this is a technique which is the gold standard for a very small kid. If you use this technique, you don't need to make any tunnels. So there is zero risk of any kind of a growth disturbances.
So, sir, what is this technique and whether we have to take any grafts for this? And
So very good question. So in this Mininder Kocher technique, we take the graft from the tensor fascia lata. The fascia lata which is on the lateral side of the thigh. What we take is we take a long strip of the fascia lata, approximately 10 to 15 millimeters in diameter, and we reroute it through the posterolateral aspect of the femur, and we pull it anteriorly through the anterior part of the tibia. And this whole procedure or this whole technique is done without drilling any tunnels into the tibia. So this is the gold standard approach for any child to me whose age is less than 11 or 12 years. When there is a lot of growth potential which is remaining, then this is a very good technique, and you can be very, very sure that there will be absolutely no growth disturbances whatsoever with this technique. So this is for very, very small kids. If the age of the kid is little more, like you say around 12, 13, maybe 14, you can have a modification of Mininder Kocher technique, in which what you can do is you don't make a femoral tunnel, but you can make a tibial tunnel, and you pass the fascia lata through the tibial tunnel. There are two modifications for small children, small kids, no drilling. For a slightly more aged kids, no femoral tunnel, but a tibial tunnel. Two different techniques to do Mininder Kocher technique, and absolutely no screws at all.
And sir, there was one more technique described known as a physial sparing ACL reconstruction.
If the child age is little more, like maybe 12 to 14, 15 years of age, you can do what is called as an all epiphyseal ACL reconstruction. That basically means is you don't cross the physis. You drill your tunnels totally into the epiphysis on the femur and on the tibia. So this is what is equivalent to almost like an all inside ACL surgery. You need to do it either a fluoroscopic guidance or a CM guidance, and you should ideally use a outside in method to drill the tunnel, because we don't want to cross the physis in these circumstances. So these are important techniques. So all epiphyseal technique is important. So that can be used. So this is the third modification, and I will usually use this technique in about 13 or 14 years of age.
So apart from this, there are some techniques where they describe that placing a tunnel more vertical can be...
Yes, so a child who is almost nearing the maturity. So in girls, if you say about 13 to 15 years of age, and in boys, maybe around 15 to 17 years of age, what we can do is what is called as an all inside equivalent ACL reconstruction, in which we make vertical tunnels. The tunnel should be more central. We don't put any screws and fix on both the sides with buttons. So that will lead to absolutely no stress on the lateral part of the tunnel. You make the tunnel more smaller and more circular. So it is known that if your tunnel is more circular or the physeal scar is more circular, it will involve less physis. If it is oval, it will involve more physis. So that is why in these circumstances, I would recommend a tunnel which is more vertical on the femur and more central on the tibia. If you use that sort of a technique, there are very less chances of growth disturbances and deformities which can appear. So these are the things, if you take care of these basic principles of pediatric ACL, then you should be able to give very nice results to your pediatric patients as well.
Sir, in some patients, can we do the primary ACL repair as well?
Yes, so that's a very, very good question. So primary ACL repair is now being a very established technique for adults also. So whenever there is a Sherman type 1 and in some cases with Sherman type 2 in adults also, we do primary ACL repair with or without an internal bracing. The good part about kids is they heal very well. So if this is a similar injury in a kids in which like the age is less and there is a Sherman 1 and Sherman 2 type injury, definitely primary ACL repair has got a big role because these children will heal very well. They have got a very good healing potential. And even if you can put 1 or 2 anchors and repair the ACL back onto the femoral footprint, these guys will have a very, very good result.
Thank you, sir. So, as he told us so many things about the different techniques of the pediatric ACL reconstruction, it is recommended that pediatric ACL should not be left alone and they should be treated as early as possible, as kids have more activities to do. They are more active than adults. So we recommend you to not to avoid these injuries in the pediatric age groups. And if you have any queries about these, and if you have any your reports or any patients who is suffering from ACL injuries, then you can contact us. Our numbers are there, and we will be very happy to help you.